and we'll get going. All right, so we've already gone through all the things about me. I would absolutely give credence to my training in Philadelphia, and at least this week I'm claiming to be a proud Gamecock. I'm not sure, depends on what the football game looks like on Saturday, but happy to be a part of Inova. I've been here for the past decade, which is crazy to say, but I'm very proud to be part of our residency training committee and training our Inova people as well. So realistically, two of the things, and you may not realize this, but you are on the forefront of the hot topics in foot and ankle surgery, and that is bunions and hammertoes, as well as total ankle replacements. And we're going to get into both of these this evening. So starting with bunions, I can't even begin to tell you how many patients come into the office and say, I'm not even sure that I have a bunion, but I've looked online and I think some of my symptoms are the same. So really, I think the best place to start is, what exactly is a bunion? Sure, you are seeing that kind of bump on the outside of the foot. You're feeling the shoe has become a little bit tighter. You're maybe starting to see your second toe curl up. But the reality of it is there are some adaptive changes occurring underneath the skin and really to the first metatarsal, which is that long bone behind the big toe, as well as the joint that make up the first metatarsal phalangeal joint, the big toe joint. And so realistically, even though we have a lot of sort of cutesy names for things in foot and ankle surgery, a bunion is a malalignment of a joint. And as you can imagine, anytime we have a joint that's not functioning the way that it should, it's going to cause pain and stiffness and deformity to other parts of the foot. The troublesome part about this is it tends to be a progressive deformity or disorder. And a lot of people will come in and say, I've always noticed that it's been there, but I didn't necessarily have any pain with it. So who's affected by this? Well, realistically, it's more common than you think. 1 in every 5 people will be treated for some type of pain related to their bunion. Perhaps not surprisingly, because women's shoes do tend to be a bit more prohibitive than our male counterparts. Women do make up the bulk majority of these patients. It is definitely something that we see worsens with age, and whether that's just that the joint becomes a little bit more stiff or the progression that we talked about catches up with us, it is certainly something that is progressive. Additionally, there are hereditary components. So a lot of patients will note that their mothers or grandmothers or fathers had bunions, and so that's certainly something to pay attention to, as well as some of our rheumatologic conditions. So the symptoms that will typically start will begin in this sort of early initial phase with just this pain and soreness. And then eventually, as the sort of disorder progresses, you will have this sort of soreness and inflammation, sometimes even redness, burning, and numbness. There is a large nerve that runs right along the side of the big toe. And you can imagine anytime we put pressure on that nerve, whether that's by putting the foot into a shoe or just the deformity and the extra prominence pushing out on that, that can become quite sensitive. So how do we make this diagnosis? Well, it's certainly something that you can see from the outside, but we do a very thorough workup. And that involves x-rays during your visit, a clinical exam, meaning what does it look like when you and I look at it and we move the joint and we look at the foot as a sort of unit together, what exactly is going on, not only with the bunion, but the rest of the foot. And a lot of times we're talking about your symptoms, your story, the things that you've tried, and then I'm going to weigh in on the things that we can perhaps offer, both from a conservative and a surgical option. Very rarely do we just jump right to surgical care, but I will say, as many bunion patients will also probably attest to, that the frustrating part about conservative care with bunions is that you're mostly doing it by the time you come to see me. This is pretty intuitive care. Sorry, I've been sitting in here too long. My lights just went off. But this is pretty intuitive to the actual deformity itself, meaning that you are typically seeking out wider toe box shoes, silicone spacers, alignment splints, bracing, anti-inflammatories, and sometimes, unfortunately, modifying activity. With regards to surgical options, there's a variety of options that are available to a variety of patients. And it really, again, kind of goes back to that meeting that you and I will have, or you and whichever bunion surgeon you choose to sort of pursue, we'll discuss. And that's really going to involve our radiographic exam, our clinical exam, and then certainly what our goals for your surgical outcome are. The best part about this is, as a minimally invasive surgeon, we have a lot of options for a variety of conditions. And keep in mind, we're going to talk about one sort of solution. Each bunion is different, and our goals with surgery are different, but the bulk majority of these, fortunately, can be approached from a minimally invasive or percutaneous procedure. So how does this work? Well, initially what will happen is I will make a small skin incision just behind that bump or that bunion area. Once I do that, I'm able to isolate all the soft tissue structures out of the way of the cutting instrument. And I will then make a transverse osteotomy, or a cut in the bone, with what's called a Shannon burr. This is a very narrow instrument that allows us to be very precise with our measurements. Once I have made that cut, I'm then going to cut and shift and rotate the bunion into the correct position. That will allow me to not only narrow the foot, but perhaps even more importantly, realign the joint. And again, that's going to be essential to getting you back to activity, getting you into the shoes that you want to wear, and pursuing a sort of pain-free existence at that point. After we have inserted the screws, I will then come in and shave off the remainder of the bony prominence. And that really serves to further narrow the foot and give this sort of very streamlined appearance to it. Over time, as this bone continues to be under stress, and that occurs while walking, the bone will continue to sort of grow in and around the screws, providing a solid and stable environment. So tell me about the recovery. Realistically, this is the best part, honestly. Most of my patients note that there is little to no pain. Our research studies show that on average, open bunion surgery patients take anywhere from 2 to 3 weeks of regular narcotic use. Our minimally invasive patients are reporting 2 to 3 pills in total. That's quite a drastic difference. Certainly, patients are utilizing Motrin and Tylenol, but the minimization of narcotics has been huge. Additionally, what we found is that we're able to move you right away. We do provide a boot and a surgical shoe to assist with this. This will protect the bone cut and the bunion surgery, as well as the skin and the tendons around, while everything is healing. And we will then transition you to a sneaker at about the 4 to 6 week mark, just based on your swelling. And sometimes we've done other procedures with this that may limit that. Our goal is to typically have you back and into your normal activity and your normal shoe wear at about 3 months. I do tend to see you every month to take x-rays of the surgical area, to make sure that our goals are being met and that you are having no issues with the actual surgical site. We do that sort of monthly in the beginning, and then we spread that way out as everything is healed and you move on from the actual surgical perioperative period. So it makes a big difference for people. It's been a game changer with regards to the way that we look at bunion surgery, the way that we treat patients, and certainly getting you moving and minimizing your pain are essential to our success. So what are patients saying? This was one I heard this week that I thought was so amazing. I had to laugh, but I had a patient that told me he was alarmed at how little the pain was. And I asked him what he meant by that, and he said he was afraid I hadn't actually done the procedure because his foot just felt a little swollen. I would say that's probably a little bit on the dramatic side. Most patients do note some soreness, but again, we're noticing a significant decrease in pain and swelling for these patients, as well as an increased rate of return to activity. Minimal scarring. So because this is big work done through small incisions, we are able to minimize the scar use. I'm also very careful to start you on a scar tissue massage sort of program as we get to the appropriate part in your recovery. That is not only to sort of maximize your cosmesis, but also or the way that it looks, quite honestly, but it's also to maximize the way that you feel in the shoe. And also, I've noticed throughout my years that it's quite incredible how many patients report a change in balance and a change in activity. And you can imagine with some of these large bunion deformities that are twisted and the toe is twisted, that it's quite difficult to have an active lifestyle on that. So again, just a game changer, I think, at the way that people are looking at this. And even from a patient perspective, I know so many patients come in and know other people who've had bunion surgery. and the horror stories that some people have gone through from a pain perspective and a result perspective, and that's really sort of changed the game for us. Another game changer is total ankle replacement, and that is really, again, the sort of technological advances that we've been able to apply to foot and ankle surgery. And the real question is, who on earth needs an ankle replacement? So many people come in and don't even realize we can do this, but just like knees and hips, arthritis is a big reason that we replace ankles. And realistically, 1 in 10 adults over the age of 65 is unfortunately going to be a victim of ankle arthritis. We know that a large majority of this is because of post-traumatic arthritis. So patients who have had ankle injuries, fractures, repetitive spraining, certainly those patients with inflammatory pathology, rheumatologic conditions, even gout can cause quite a bit of damage in the ankle. And then certainly we have also the patients who deny any sort of acute trauma, but instead have sort of this very sort of generalized deformity. Patients with long-standing severe flat feet or severe cavus feet, those joints tend to wear a little abnormally as well. It's interesting if you really think about the anatomy of the ankle, and you know, if you comparatively, if you look at your knee and your ankle, and even consider your hip, it's quite a small surface area comparatively. But interestingly enough, it's going to tolerate and sort of load about 4 times your body weight every time you take a step. Although the ankle is going to be certainly a little more prone to small arthritic changes than your knee or your hip would be, we know that about 9 times as many people are going to suffer from knee arthritis as they will from ankle arthritis. So again, you'll come into the appointment and certainly we'll talk and look at the imaging and examine the ankle. But we always like to talk about conservative options for care as well. And certainly with any arthritic condition, what we find is that bracing can be a great intermediary. Certainly corticosteroid injections are very, very helpful, and even sometimes physical therapy. Some of these braces do tend to be pretty aggressive, and a lot of patients eventually come to the unfortunate conclusion that injections are temporary relief. So there are surgical options, and I've listed a few here below, but we'll focus on ankle replacement this evening. So what is an ankle replacement? Well, it's essentially where we're going to cut out the old arthritic and deformed joint, and we're going to replace it with a titanium and cobalt chrome interface. And basically the ankle itself, the replacement rather, is going to be made of 3 parts. So you'll have the tibial component, which goes into the leg. You'll have the talar component, which sits on top of the talus. And then you'll have the poly, which for all intents and purposes allows the joint to move. Not everyone is a good candidate for this. And realistically, we have to be very careful with joint replacement surgery, just like in knees and hips, because these are artificial joints. They have a certain expectation and limitation. And so we want to ensure that we are signing you up for success. There's, again, certainly lots of procedures that we can do, but a typically good candidate for an ankle replacement is someone who is slightly over the age of 50, a BMI of under 35. Non-smoking is almost an essential component of our preoperative workup and discussion. And even though diabetic patients can safely undergo joint replacement, in the foot and ankle, we are very careful about monitoring blood sugar and making sure that your A1C is below the level of 7. And that's all just to prevent not only acute surgical complications, but also making sure that the implant is in the best position possible to last you a long time. So how would this work? Well, again, you would come into our office. You and I would go through your x-rays and again, your clinical exam. Oftentimes we are looking at the foot and the ankle. We know that it is so important to take all of that into consideration because the ankle will function much better if it is on a stable platform. I will then typically send you for a CT scan. Our CT scan uses something called PSI, or patient-specific instrumentation. And this is where this surgery gets really cool. So within the last decade, we've been really able to advance these procedures by creating a CT scan with a certain protocol. And many companies have this, it's not just one. But essentially, what it allows us to do is formulate a cut guide for each patient individually. Even though you and I may have feet or ankles that look virtually the same, there are tiny nuances that will optimize or perhaps be detrimental to the wear of the implant. And we want to make sure we're taking all of those into account. Once that is made, all of this instrumentation is going to sort of be fitted for you. Now, realistically, if you look in the picture on the very bottom of the screen, there's a white object in the middle, and that's the cut guide. All of the other instrumentation is sized according to that, and the plan that honestly is about 20 pages long of us to look at your alignment. We're basically taking a scan, a CT scan, essentially from the knee to the tips of your toes to make sure that we are putting this in the best position. So again, here's a closer look at that sort of patient-specific instrumentation, a better view of that sort of white cut guide, and you can see the leg or the tibial component as well as the talar component. And minus my ID tag, all of this instrumentation is pretty standard to the ankle replacement surgery. So here's a closer look at one of our implants that is available, just to sort of give you an idea. You can see this sort of pegged prosthetic. So the implant is basically fitted and drilled into the tibia and then press fit. You can also see that poly, which is designed for this optimal longevity. It's made out of very specific material and held to very very specific criteria before we put it in. We're very careful not to even really touch this to prevent any sort of wear and tear. And then another thing that's a little bit more techy and more surgeon driven, but another sort of advancement in our technique is that we're using what's called a chamfered talar dome cut. And that's really important because we are minimizing the amount of bone that we are resecting. I find that often sort of weirds a lot of people out, that we're cutting away some bone, but we want to be cutting away the deformity and cutting away the bad bone as little as as much as we can to fix the deformity, but as little as we need to sort of preserve the normal anatomy of the ankle. So what is the surgery like? Well, this is typically done in a hospital. The surgery itself is about 2 hours long, sometimes longer, depending on the procedures, and certainly some of the osteophytes and arthritis. This is a patient of mine on the right, and you can see his motion is just phenomenal. I muted the video because we're both just kind of gushing at how awesome he looks. You can see barely, but you can see the incision on the front of the leg. Again, we take a lot of pride in the way that we close these things, not only because we want them to be comfortable and we want them to look good. We want to minimize the risk of wound issues, which is really important with any joint prosthetic. You'll be in a splint for about 2 weeks, and then we will put you into a boot. The stitches come out at about 2 weeks in the office, and typically we are allowing some pressure and loading of the ankle at about that 4 to 6 week mark. I'm not usually one that insists on PT for a lot of conditions, but this would be one that I absolutely strongly encourage it. And that is so that we can optimize your outcome and get you back to function in the safest and most efficient way possible. So things to know, the success rate of ankles are very close to rivaling those of our knees and hips. Their survivorship, meaning how long are these ankles staying in patients, is well over 90% at 10 years. And I think that those numbers are going to continue to increase, which is amazing. We take 90% in medicine any day. Most of our patients are returning to normal walking and especially low impact activity. That means walking, biking, golfing, all kinds of things. And mostly the sort of improvement in deformity and pain has been, again, a big lifestyle change for so many people. So that's all I've got for you tonight. Here's where you can find me. I'm at the Inova Prosperity location at 8501 Arlington Boulevard. You can make an appointment either via phone through our awesome call center, or you can certainly schedule via MyChart even. I think we've got all that up and running. But